I'm Dr. Kevin Smith, and today I'm going to be talking about treatment of sleep onset association disorders in infants and toddlers. So I'm going to discuss the characteristics of a sleep onset association disorder, but I want this to be a practical talk today, so I'm really going to talk about some strategies that you would be able to use to treat this disorder in your clinic. And then at the end of the talk, I'm going to identify some easily accessible resources, not only for your families, but for you and your colleagues. So sleep onset association disorder is actually a type of a larger disorder called behavioral insomnia of childhood. And as you can see on the screen, there's another type, limit setting. You could also diagnose both or unspecified. I'm not going to be talking about limit setting today. It's basically what it sounds like. Parents have difficulties setting limits at nighttime, which affects bedtime, because to me, the treatment is similar to the behaviors that you would see during the day, and I think that can be found in other talks. So today I'm just going to focus on sleep onset association disorder because it's a more nuanced treatment. So we'll start with the clinical interview. In addition to getting your medical, psychosocial, developmental history, one area that you want to screen for is possible medical sleep disorders because they could maybe better describe what is going on with your patient. So like sleep apnea, restless legs, parasomnias. Now that's beyond the scope of my talk today, but you'll see on the bottom of the slide that I've identified some questionnaires. They're all public domain that you could use in your clinic, and a few of them get both behavioral and medical issues in one. And additionally, you want to screen for any medical, non-sleep medical issues that could be contributing to sleep problems, such as eczema or reflux. Then you want a good behavioral sleep history, looking at sleep patterns, sleep scheduling. I find total amount of sleep is a great place to start. Often parents are either under the assumption that it should be less or more, so that's a good place to kind of anchor the talk. And then I find out what they've tried in the past and what they've been told. This is another screening tool that I like. It's the Bears sleep screening tool. It's really easy. It's just one page. It's not something you score. It's a great way to just start the conversation with the family about sleep issues if that's not why they're coming to you specifically. So, sleep onset association disorder. Mainly what this is a child learns to fall asleep under certain conditions at bedtime, and then those conditions have to be readily available in the middle of the night, or falling back to sleep is difficult. Generally, this involves the caregiver, and it's either something like rocking or holding, feeding, things along those lines. And then during the night, they can't fall back to sleep because the parent's in bed. This is a common issue, and it's probably the most common issue I see in the Sleep Disorder Center at Children's. And one thing to remember, we wouldn't diagnose this in infants under 6 months. We wouldn't expect them to sleep continuously at that point. So I want to take you back to, if you took Psych 101 in high school or college, take you back a little bit and talk a little bit about kind of the tenets of sleep training, and it's really based in behaviorism. And one type is classical conditioning. So remember the Pavlov's dog experiment. So using sleep as the example, the unconditioned stimulus is the sleepiness in bed at night, and then the unconditioned response is falling asleep. But when you pair that unconditioned stimulus with a neutral stimulus, thank goodness the slide is here, right? That's a lot of stimuluses. Parental contact at the time of sleepiness, then the child becomes conditioned to need the parental contact. Another example would be operant conditioning. That's basically reinforced behaviors will increase and ignored or punished behaviors will decrease. For older kids, you can use positive reinforcers like stickers. I think for families, there are two pieces here that are sometimes new information. Attention, any sort of attention, even bad attention, can end up being an unintentional positive reinforcer and then keeping that behavior going. The other component is continuous versus intermittent reinforcement, and I will talk more about that when we talk about the treatments. And we have one more thing to do before that. I want to talk about room sharing in the 0 to 12 month group. So the American Academy of Pediatrics came out with a position paper in 2016, and there was one big change. Instead of recommending room sharing for the first 6 months, they extended it to 12 months. Now, this becomes challenging when you're sleep training, and in fact, it conflicted with a lot of expert sleep guidance. So another paper in 2017 came out, part of the Insight study, and those research found that that kiddos who are room sharing actually are more likely to end up in their parents' bed, which we don't want, more likely to have pillows or blankets around them when sleeping, and even less likely to have a consistent bedtime or sleep routine. Now, the main reason for the initial recommendation was SIDS prevention, and some of the researchers in this Insight study were concerned about the data not supporting that, and again, it conflicted with expert sleep guidance. So in medicine, things are nuanced. And what I would recommend is checking in with the family around age 4 to 6 months. How are things going? If they're still room sharing and things are going well, wonderful. Keep it up and everybody's happy. But for the families who may be struggling, maybe the parents are getting a decrease in quality or quantity of sleep, which is expected but beyond norms. Maybe they're resorting to unsafe practices to soothe the child, such as co-sleeping. I want them to have options. So for me, if I have a family with a 10-month-old who wants to share a room and co-sleep, share a room, wonderful. If they don't, though, I want them to have options. And there's definitely research to support sleep training past the 6-month limit. Okay, finally, talking about some interventions. Before I recommend any intervention, I really want to focus on the family establishing a consistent sleep schedule and a good bedtime routine. So let's assume that that's established. So one intervention is called standard extinction, and that's more commonly known as the cried out method. I hate that name, and we'll talk about why later. But basically, the parent puts the child into bed, drowsy but awake, leaves the room, and then does not go back in and will ignore the crying not only at bedtime, but in the middle of the night. Then there's graduated or modified extinction, and I call it the check-in option, where parents will leave the room, stay out of the room for as long as they can, go in and make quick visual contact with their kiddo, and then when they leave the room again, they just try to stay out of the room a little longer each time. And the kiddo falls asleep in between those check-ins, and you have a kiddo that's falling asleep independently. And then there's the extinction with parental presence. That's just the parent starts out in the room, and then we slowly fade their presence out of the room in multiple steps. And so for the graduated extinction and the extinction with parental presence, you're using that at bedtime, but those skills will generalize to middle of the night. And that's the issue, really, is that the child does not have the sensation of being alone in their bed or crib at night. And so by helping them with their self-soothing skills at the beginning of the night, that's going to generalize to the middle of the night as well. So this is just kind of a visual I put together to show the many steps where a parent could be in this process. So if you look at the starting line, that's going to be a parent who we might start with a extinction with parental presence. And so the pictures show kind of more intense contact, and they go from the more intense to the least intense. So with the first photo, you see the mother is holding a child breastfeeding, and then putting the kiddo to bed after he falls asleep. Second is now in bed but touching. The third picture is in bed but not touching. Fourth, outside of the crib. You get the idea. And so one of the most important things is to find out where the family is at baseline. Where are they starting? And sometimes families will forget a variable or two. So really finding out what are the discrete components to the sleep association, and that's going to help you to find a starting point, which is going to help you be more successful with treatment. So I think these are pretty straightforward protocols. Again, they're based in behaviorism. They're not that complicated, and families tend to understand them pretty easily. The problem is all of the variables that can affect implementation. So things that I've seen, probably the number one is try to determine the true level of motivation and readiness for change. We all know that sometimes parents, caregivers will do whatever the doctor says because there's a power differential. You really want, though, to have the words match the actions and let them know that it's okay if this isn't the right time. Sometimes there are upcoming stressors. If it's the holidays, you're going on a vacation, that's not really the time to start this protocol. In fact, if possible, I often recommend families start it on a Friday if they work Monday through Friday. The other thing is if there's more than one caregiver, you want to make sure both are on board, and I usually directly ask both. Because if not, that's going to sabotage the protocol. And oftentimes, if they both aren't in agreement, you can find somewhere on that continuum, that slide I had with all the photos. Maybe if mom isn't comfortable with extinction, she could be comfortable starting out next to the bed with the child in the bed. So you can work to help caregivers come to an agreement. You might not be able to, though, but it's important to address that right at the beginning. There's real life factors. Some kiddos have siblings and they have to sleep. And so coming up with some strategies, maybe using white noise in the room, maybe a child can temporarily move bedrooms, maybe that's not an option and everybody gets a little less sleep. Talking through that with the parent, again, doing this all on the front end. Some families live in apartment buildings or have very close neighbors who aren't very tolerant. Got to come up with a plan there because there probably is going to be some crying at night, and that could disrupt neighbors. And then it's not just the caregivers sometimes that are putting their kiddos to sleep. You got extended family, you have babysitters, even preschool teachers. So really getting everyone on board, everybody doing the same thing is going to increase the chance for success. Then there's caregiver factors. There's going to be a difference in the tolerance for crying based on your individual families. Really having a good conversation about that. If there's significant concern, exploring more what that is. Sometimes I even end up talking to parents about how they were parented. So you can go a little farther back if you have to. There's guilt associated with sleep training, and that's usually families who aren't familiar with the research, which I'm going to be talking about in a second. And then just make sure they have really clear expectations and are they realistic. Finally, for preschoolers, it could be a case of nighttime fears. Now, we're not going to really talk too much about that today, but I do have the references that I'm going to highlight at the end, give parents ideas on how to treat that, and I have a list of books, too, that they can read with their children. And finally, under the things to consider is cross-cultural differences. Co-sleeping, room sharing is, in some cultures, the norm. And so, again, this needs to be a choice for families. You see on this slide here, this is from Dr. Jody Mandell's research in 2010. You can see on the map on the left that that looks at different bedtimes across countries, predominantly Caucasian and Asian countries. That's what this study was about. They, I believe, surveyed over near 30,000 families for this internet survey. And then on the right, you can see that room sharing frequencies vary greatly. Here's another example. This is global bed sharing prevalence rates. This was a meta-analysis where, as you can see on the heat map, red would indicate more bed sharing and green indicates less. So you see really the huge differences. So again, it's okay if bed sharing is what a family wants to do, as long as it's safe, they're not too young. But the great thing is you can still do sleep training. You can still have someone, if they're sharing a room or a bed, work on helping the kiddo to fall asleep independently, regardless of where they're sleeping. So there are some contraindications. One of probably the top two on the slide, or the top two that I see, medical issues that would exacerbate prolonged crying. things like asthma, other breathing issues. I will say that often the families who tell me that haven't necessarily checked with their medical team to see if that would be a concern. So if they don't know for sure, I always bounce them back to you guys so that they can get clearance, or we come up with something else. And then young children with a severe history of trauma that hasn't been treated. Oftentimes trauma happens at night. I'm not going to recommend sleep training at that stage. Changes in home environment, kiddos that maybe just have been newly adopted and living in a new environment, not going to recommend sleep training at that stage. And then other developmental issues such as failure to thrive, and again, infants under 6 months. But you can still encourage a good bedtime routine. And sleep training can work for kiddos with autism spectrum disorder too. Sometimes I find it might take a little longer. So, what's the number one concern? My baby will cry for hours. Most babies don't cry for hours, but they cry. The treatment course is brief. There's no short or long-term negative consequences. We'll talk about that research in a second. But again, this is a choice. So if families are not ready for this, you don't want to start, because they could circle back. I've had that happen in my practice. And so I don't want to damage that rapport. I want to keep the lines of communication open when they are ready. You'll see at the end of this slide, it's kind of abrupt, I know, but your child may vomit. And that's probably the number one thing that a child could do during this that really, as you would understand, upsets parents. What I recommend is having some linens on hand, having a change of pajamas on hand, and to go in and as quickly as they can, clean everything up, obviously make the kiddo comfortable again, but then get out of the room. We don't want to create a situation where it's actually inadvertently rewarded, which could create more vomiting. So the second question I get is, how long is this going to take? And so these slides was given to me by permission from Dr. Honecker. This is her research that was done in 2018. Let me just review the categories real quick. Unmodified extinction is leaving the room and not going back in. Modified extinction is the check-ins. They call this parental fading. And that's basically extinction with parental presence. And then parental fading with assistance means being in the room, but maybe rubbing the kiddo's back, holding their hand, something like that. And you can see that the majority of families, the sleep onset association disorder, it's a mouthful, was resolved within 7 days. Now there is variability, and you see that yellow column is over 30 days, and for some of the protocols, that definitely happened frequently. How much do they cry? This is a survey of the first night, and you can see that it is around the 40%. So if you take the first example, the unmodified extinction, it's around 43% of families said that their kiddos cried that first night. How stressful is this? Yes. There's the answer. It's stressful. If you look at this slide here, it's a scale of 1 to 5, 5 being the highest, and we're over 4. So this is stressful for parents. I try to prepare them for that. Again, being as upfront with you as you can with families, but not scaring them either. They can do this. Most families can do this. But it's going to be a tough first couple days. Fortunately, you see the stress levels drop, and I think this was day 8 on this slide. Parents are also concerned that sleep training will make their children feel abandoned, could damage the relationship between parent-child, the attachment. This study was done in 2012. They looked at 2 groups of kiddos 5 years after the sleep training. So one group had sleep training and the other didn't. They didn't see a difference in attachment. In the group with sleep training, they actually saw improved child and parent sleep, lower rates of maternal depression. This is a well-researched protocol with good, solid evidence behind it. But again, providing the family with realistic expectations and outcomes is key. Dream feeds, I'm just kind of throwing this in with one slide. You probably, I bet you're aware of this, and you might even use this in your practice. It's waking an infant a few hours after sleep onset. And what's nice about that is that often coincides with when the parent goes to bed, so that saves one awakening for the parent. Gently wake the child up, complete the feeding, and then put them back in the crib. And then you're going to recommend the parents respond to all the other wakings consistently, but do not feed. And what this can do for some families is create longer stretches of sleep at night for the kiddo, and it can be useful for children who still need nighttime nutrition, maybe as a failure to thrive, some other medical concern. So a quick case study. This is Danielle. And this isn't an exact, I didn't pull this from notes or anything, but this really represents a family that I would see often. So mom has always held and nursed her to sleep beginning of the night. Then she puts her in the crib around 7:30. Danielle's waking up 2 to 4 times a night. Oh, important to tell families that waking up is normal. That's a normal part of sleep. If the goal is to have your child never wake up, that's not going to happen. It's what happens after that we can help them with. So she's waking up 2 to 4 times, pretty normal. Sometimes the parents will try to cry it out for maybe 15 or 20 minutes. Sometimes they go in immediately. It really varies from night to night, and it's based on what is going on the next day. That is really common. When I see parents, almost always, they're in survival mode. So they have come up with a series of responses to this that change from night to night based on the night. And unfortunately, then that perpetuates it. So I try to acknowledge that because they know that inconsistency is probably not going to get them to the finish line. But, real world, especially if it's Sunday night and you have a meeting Monday at 7 a.m., you're going to do what you have to do to get your kiddo to sleep. So mom nurses her back to sleep for the first couple of awakenings. This happens often. And then it's 3 a.m. It's like, oh, just put her in bed. I mean, we have to get up tomorrow. And then grandma comes in with her advice. I just left you in the room so you could just have her cry it out and everything will be fine. But mom is worried about the effect that might have on emotional attachment. So a lot of these variables are similar to the things that I discussed earlier in the talk. So what would I do? Well, you want to address the beginning of the night first. How you fall asleep is how you fall back to sleep. Now, I will say the middle of the night is usually what the parents have on the top of their list, and I always tell them we are going to get to that. But you got to build those self-soothing skills first for them to be able to use them in the middle of the night. So one thing I would focus on with this family is to try to move the feeding earlier in the bedtime routine or maybe even out of the bedroom. So if you look at what components the sleep onset association disorder has for this family, the kiddo needs to be fed, maybe rocked in her room, outside of the crib, and then needs to achieve sleep before being placed in the crib. So if I was doing a extinction with parental presence, I'd pick one variable, and it would be the feeding. So I would just try to start by moving the feeding back, and I would leave everything else the same. So if you have a family who's pretty anxious about this, that seems like a doable step. Then I would say, could we focus on the feedings in the middle of the night as well? And see if we can address those. I probably wouldn't start with standard extinction because mom had said she was concerned about attachment. But again, I try to present all the options. I use steps as an analogy. So you can either take smaller steps and it'll take you longer to get to the top. So that would be, starting out in the room and fading out. Or you could put a big bow on it, take one big step, leave the room and close the door. But that's a hard step. And I just want to meet the parents where they're at and really get their buy-in. So, final slide, increasing the chance for a successful intervention. What they need from you, and sometimes what I need from you, is medical permission. They need, if there's any concern about prolonged crying, they need permission to do this. They also, if we can start fading out the nighttime feedings even before, This starts for kiddos that are old enough. That's just one less thing to manage. It's not necessary, but at least having that discussion and making sure that they have permission to do that. Say the kiddo's 14 months old and you have a discussion telling them that they do not need to get nutrition in the middle of the night. They're going to come in with the cry it out and tell them there are many other options, but you don't have a no-cry method. I know there are books out there are websites out there. I just haven't seen the research support that. Personally, I don't have an intervention that I can guarantee no cry. So again, being not scaring families, but just being upfront. Finding that right starting point, spending the time early on, thinking about that slide with all the photos and finding exactly where to start really helps. And then finally, I know I've said this 3 or 4 times, but this is a choice. If they aren't ready, that's okay. You can give them information at that time. But if they are saying they're not ready because they're waiting for the kiddo to grow out of it, well, I see a lot of 5-year-olds, I see a lot of 8-year-olds, I see older than 8-year-olds. It could happen, but my experience has been that more so that they don't grow out of it. I mean, it's pretty awesome being able to have your parent help you to go to sleep. So why would they want to change? And finally, I alluded to this earlier. Here are some resources that I pulled together. There are a lot of books I would recommend, but I try to take the Costco approach. You go to Costco, and if you want peanut butter, you get 2 options. And you usually pick one. So I picked the two of my favorite books and 2 of my favorite websites, and they're on this slide here. These are the books that I referenced that address nighttime fears, and they range in age. Here are some resources for children with autism specifically. Some good visual sleep schedules, help parents put those together. And then resources for you. Again, these are my 2 favorite books. And I just discovered this website not too long ago, basisonline.org. It's out of the UK. It's really well done, and it's also for parents as well. Finally, I think I said finally previously, but this is finally, sleep questionnaires. Again, you may want to incorporate one of these into your practice. These are all public domain. They're all quick to give. They're all free. Thank you.